everyone, and welcome to today's episode of the BSG Trainees podcast. I'm Rohit Kumar, and I'm joined by my co-host Sonika Sethi. Today, we have the pleasure of speaking with Dr. Philip Smith, who is a retired consultant luminal gastroenterologist and is now an honorary consultant gastroenterologist at the Royal Liverpool Hospital and honorary senior lecturer at the University of Liverpool. Throughout his career, Dr. Smith has been heavily involved in the training of future gastroenterologists as well as academia. He is currently the Deputy Editor of Frontline Gastro and also the Educational Editor of Gut. Thank you for your time today, Phil.
You're welcome. Thank you both very much in the BSG training section for inviting me. It's a great privilege to speak to you and impart my dulcet tones and thoughts and maybe a tiny bit of wisdom, but certainly in my opinion. Thank you very much for inviting me.
So what inspired you to enter the field of gastroenterology, and has it always been your area of interest?
Great question, and thank you for asking it. So, essentially, I'm an outsider in medicine, always, or at least I've always felt like that. So, I'm from a non-medical background. My dad, who's recently passed away, worked in an abattoir in North East Manchester, and my mum was a home care assistant and never went to university. So I was the first in the family to think about doing medicine, and it was a bit of a voyage of discovery for all of us in our family that I was trying to do this. But what kind of prompted the gastroenterology side of things was, unfortunately, from about the age of 10 onwards, I started with symptoms of diarrhea, abdominal pain, weight loss, etc. And unfortunately, I was diagnosed with Crohn's disease myself, quite advanced Crohn's disease by the time I was actually diagnosed. And so from that, I gained a lot of experience as a patient, clearly. In those days, treatments for Crohn's disease were steroids, enteral nutrition, and azathioprine. How things have changed, of course. And, of course, surgery. It really generated a lot of interest because I saw how doctors particularly worked, saw how they worked when I was an inpatient on the wards, paediatric wards at that time, but also as in an outpatient. And I thought, you know what, I could do it. And it kind of lit a fire in me that I wanted to be a doctor, that I could be a doctor. I had a bit of a chip on my shoulder probably as well, that I am going to do this, nothing's going to stop me sort of attitude, and was really up for the challenge. Just so you know, because my mum might listen to this podcast afterwards, my mum was desperate for me to be a journalist of some sort, so I really went off-piste when I said that I wanted to be a doctor.
And can you share a bit about your journey and what the key milestones were in your career as a gastroenterologist?
Yeah, I mean, it's been a long journey, and it's been a tough journey, including to where, I am now as recently retired. So I guess the starting point was medical school. Medical school, I wasn't very well with my own IBD, saw lots of IBD from that perspective, and met with a professor called Professor Hawkey in Nottingham, where I was at medical school, who was a very big name in the BSG at that time. Just coincidentally, of course, all of this, that's where I ended up. When I qualified, I did my very first job as a pre-registration house officer, PRHO, in a gastroenterology job, which inspired me. We then, my wife and I now, Bev, we moved down to London, got a great medical rotation. I did want to be a paediatrician initially, a paediatric gastroenterologist, but looking after kids and their parents, managing those, put me off a bit. So I got a good rotation in London, and then because I'd done quite a few different things, I was always trying to experience different things. I managed to get one of the few at that time, back in 2007, 2008, London ACF posts, which were a brand new thing at that time, and there was not much guidance or insight into it. So that was a key point, because that got me on the training run through effectively for gastroenterology, whether that continued in academia or in, general clinical training. I did get some a grant, a personal grant from the Medical Research Council, the MRC, to do some PhD research. Unfortunately, I literally chose exactly the wrong supervisor and supervisees to do that. I had a terrible time during my research doing IBD, but I didn't enjoy it at all. It was horrendous, actually. I was working with people that supposedly were supportive of patients with IBD, but now it was a terrible experience and slightly put me off research a little bit, but not completely, of course, because I'm still doing a lot of that. And then other milestones, becoming independent scoping, doing upper and lower GI endoscopy. I was interested in intestinal failure as well as part of severe IBD kind of viewpoint. So I got the national training number for nutrition, which was 6 months at St. Mark's and 6 months at the multi-visceral transplant team in Cambridge. That was fantastic. Really, really interesting, and really enjoyed that. And then spent a lot of time in North East Thames, rotating around. One of the main places I worked at was UCLH. I spent a lot of time there, seeing the good things that go on there, but also the not so good things that you experience with colleagues, consultants. It was a tough working environment in that part of London, not just at UCH, but just generally. And that's why it's really important that we, from my experience, that I support trainees as much as possible in whatever their circumstances are. So they're kind of the key milestones that kind of formed me as a gastroenterologist. And then the very final thing was my wife got a job as a paediatric rheumatologist in Liverpool at Alderhay, and we decided, being me from Manchester as well, to move up to the Liverpool area to continue post-CCT. So I got a consultant luminal job at the Royal Liverpool Hospital. That was my first consultant job, a fantastic job, great hospital, great colleagues. And unfortunately, during the pandemic, became unwell with my IBD, but also with unrelated complications with my stomach, and that has really curtailed my my frontline NHS career, which is obviously, as you can imagine, quite devastating given the hurdles and barriers that there have been to me getting this far. So, but I am still continuing in some kind of guise an interest, my career, so to speak, although it's ended at the very front line.
Thank you so much for sharing that. You've gone through a lot in your career, and there must have been so many memorable experiences you've had through that. And I was wondering if you could tell us about a memorable experience you had in your practice that shaped your approach to patient care, and also how has IBD changed as you progressed in your career as well?
Yeah, good question. I mean, because there's so many different patients that you carry with you. I'm sure you guys can remember several patients that kind of are kept, their memories are kept in the back of your cerebral cortex somewhere. And I'm no different. I can remember individual patients, straight off the bat. I guess the general principle that's always applied to me working on the front line was, what would I want if I was that person in that bed? And as you've heard already, I have been that person in that bed, in that hospital gown, feeling frightened, feeling despondent, feeling sad, feeling missing their family, having horrible things done to them. And so that was always kind of my approach to my IBD patients, trying to make sure that things happen for the person, that people didn't, get caught up in the system, because we know that patients can in the NHS. I thought before this interview of a few examples of patients that probably exemplified the experience I've had as a doctor. And the first example I'd probably give is a patient I remember vividly when I was an SHO, senior house officer, as we were called, and I worked in the intensive care unit in a hospital right in the centre of London, in the Euston area. And this patient had been on a ventilator via tracheostomy for weeks and weeks and weeks. They were in the bay that was like for the slow respiratory wean patients. And in that environment, patients often got labelled as they're taking a while, and they were almost uncertain patients whether these patients were going to pull through and get off a ventilator potentially, or whether they were going to eventually pass away and not be able to be ventilated and die. And I remember this particular patient had been labelled as that, quite a young guy, had come in collapsed, various history of being out of hospital arrest, etc. And I was allocated to that side of the intensive care overnight and looked after him. And I kept on noticing, because we did 7 nights in a row on night shift at that time, that every night blood pressure would go down, BMs may drop. And I thought, this has got to be something to explain this. Why is he not thriving? Why, despite everything, is he not getting off this wean? And why is this happening every night that we're having to give him bolus of fluids and etc.? And I every morning at 8 o'clock you had to present back to your consultants, and so I presented back in the morning that I thought this patient may have Addison's. He may have low cortisol, and I'd actually decided off my own back to send off a cortisol. I'd also decided to send off other anterior and posterior pituitary hormones as well, just to check a nerves. I was thinking, is this a case of panhypopituitarism? And I'll never forget the 2 consultants that were on. They were nice enough, but they laughed at me and said, "We like your thought, but leave the thinking and the smart stuff to us." That was effectively what they told me. And I remember there was these 2 Italian doctors visiting at the time and looked at me as though, "Are you going to take that? Are you going to, that was really rude what they said to you." And of course, in those days, this is back in the early 2000s, you did just take it on the chin and accept that, okay, you're in your place. Went home, came back the night shift, and guess what? The patient had no cortisol, had no thyroxine. Nobody checked the bloods, by the way, I should add. And so it was me that discovered those bloods when I arrived on the unit. And of course, by the following morning, getting the right treatment, speaking to the endocrinologist, etc., this patient was doing massively better on a ventilator. And to their credit, the consultants concerned did apologise because they remembered vividly what they'd said to me. It was quite stark in front of the entire ITU group, which was a big meeting. And that I think, fed into me feeling that, you shouldn't ever kind of push somebody down. You should listen to them, listen to their reasoning, etc. People of all grades, all different stages of their career have good thoughts and opinions, etc. And you should always take that time to inquire and find out and learn something of people. And so that was one example that's probably always stuck with me for the reasons I've explained. The second example is purely someone fairly recent who came in a complete mess, very low albumin, severe IBD, and I was the brand new consultant, and this patient was bleeding to death in front of me. I mean, they were exsanguinating, and I had to take particular steps to stop that. And the team at the Royal really pulled the stops out for this really young patient with IBD, including doing endoscopy and intraoperatively in theatre, etc. And great colleagues did that. And anyway, long story short, this patient ended up with a intestinal failure type 2. But the great team at the Royal, the nutrition team, put them back together, and they had a fantastic outcome. We managed their IBD. They got fixed back up together. They're on parenteral nutrition. It just showed how good a unit we had at the Royal in terms of intestinal failure, and that patient recognised that. Of course, we got them psychological support. We managed to get a psychologist on the back of their experience. So these are the types of patients I'm sure you yourselves will carry with you, but they're people that have stood out in my memory, and hopefully you can appreciate how I kind of approach patient care generally from just those 2 experiences.
Thank you. And what's one piece of advice you've received in your career that has stayed with you?
It's a good question. So and this is probably something that I regret a lot, is that during my career, and trust me, I wished it was different. I've not really had a single mentor that I've been able to rely on and say, oh, Dr. X has supported me, helped me get into research, helped me, given me opportunities to this, that, the other. And whilst people have helped in some ways or another, I've never really had that kind of person that has been able to do that. I've had huge support from, I should, give a shout out to the likes of Professor Al Omar, the editor-in-chief of Gut, and the editor-in-chief, Mark Beattie of Frontline, and editor-in-chief previously, Anthony Manuel. These are people that have helped me and supported me at various times. But in terms of my actual career, getting through those difficult hurdles, particularly when I've been unwell during training, I've not really had anybody that's been able to put out the hand on the shoulder or whisper in my ear and say, Phil, this is what I would do. This is my piece of advice to you. And so I've relied heavily, really, on my family's advice, my loved ones, my wife's advice. And they've been very consistent all the way through. And, people listening to this that have continued to listen to this, and I've not bored them as yet, may relate to this. And the biggest piece of advice that I've got, and again, it has come from within the family, is to thine own self be true, to always be true to yourself, not try and be anything you're not try and pretend that you haven't seen something. If you see injustice, deal with it, tackle it, so that effectively you could sleep at night. And I think that's added pressure at times, because it's meant that I've felt compelled to speak up at times of difficulty, where I've seen injustice, things going wrong. But conversely, it's also always allowed me to sleep at night, because I know that I've always tried in my heart of heart to do the right thing by my patients, and try and make the right decisions for the right reasons, as opposed to, ulterior motives. So my advice would be to get yourself a mentor and help guide you on your way, because it certainly may make career advice a bit easier than I found it.
Thank you. Thank you so much, Phil, for sharing your personal experience. I think, to me, it really highlights your passion in gastroenterology and even broader medicine as a career, especially while fighting through your personal adversity. And I think you've been such a role model to so many trainees, whether directly or indirectly through your work with the BSG. I just wanted to change pace, if that's okay with you, and shift on to your thoughts about gastroenterology and hepatology as a specialty. I was interested to hear about what some of the most common misconceptions about gastroenterology that you've encountered throughout your career.
Yeah, well, thank you. So this question made me think quite a bit, because I was trying to think, because obviously I've been so embedded in gastroenterology for so long. I was trying to think, well, what are the misconceptions, about gastroenterology? I think one of the biggest ones for me when I was starting out is that there was so much emphasis, and I think this still applies, actually. And I completely understand why it applies, of course. But I think there was so much emphasis that endoscopy was the only thing that mattered. That you had to be good at endoscopy. You had to make sure that you did the perfect colonoscopy, that you could remove the perfect polyp, that you got thousands of scopes, etc., and this, that, and the other, and that you had to be really quite dexterous, and you either had it or you didn't have it. And actually, I going through my training, I didn't really find that was true. Yeah, I think you do have to have some degree of dexterity, but I don't think you needed to be, the most dexterous person in the world, and because I don't think I probably am. And also, as a gastroenterologist, yes, endoscopy is important, and it's definitely something that you have to get signed off during your training and etc. And you need to get it right. You need to be trained in the right way, but it's not the only thing that matters. I think what matters to patients and and to become a gastroenterologist is that you can talk to patients, communicate, get to the bottom of problems, identify where the real need is, identify what the underlying issue is, understand what the patient may be feeling, because that may drive their treatment decisions. There's so many different areas of gastroenterology and subspecialty areas that endoscopy is just one area that needs to be covered. And, I'd like to think that in the future, albeit this may not come true, that trainees have that pressure removed from them, that there are some gastroenterologists that don't do endoscopy, and in fact, they may do things like small bowel ultrasound as their kind of area, or ultrasound of the liver. I mean, when I first started, people were still doing liver biopsies. That was the Gastro registrar's job, for example. So I think that was probably the most common misconception that I've encountered in relation to gastroenterology.
Yeah, it's going to be very interesting what happens over the next few years, not just in gastroenterology, but in medicine in general. I think moving on, Phil, if that's okay with you, I think, because you've got so much experience and, in this field, we wanted to hear more about your advice for young doctors, young trainees. And I wanted to ask with kind of how you've been able to balance the demands of being a consultant gastroenterologist and a prominent researcher with your personal life. I know you're a big United fan, so I know it's been a bit hard for you to enjoy the last few years. But I guess I wanted to, ask about the importance of kind of separating your work from your life and how you've done that.
Yeah, I mean, this is only my advice, and there are hundreds, thousands of other gastroenterologists that might disagree, say something very different from me. I'd like to think that I've got some insights that can be useful, but obviously anybody listening, you don't have to listen to this at all if you don't want to. I think my biggest advice would be to always really focus on what's important to you and never to lose sight in that. I think I did during my training and being a consultant. I was so committed, so passionate about gastroenterology, working, doing, trying to do various different stuff that interested me. I lost sight of what was really, really important: my family, my wife, my kids, and ultimately, at the end of the day, it's a job. Gastroenterology, being a gastroenterologist, is just one part of me. Being a doctor is just one part of me, and so just remember that. I think that's my biggest piece of advice is really remember what's important to you. Make sure you look after your health, your family, your friends, the people that really, really care about you, especially in today's NHS, which is in such a terrible, terrible state. That's really, really important. The second piece of advice would be, and you heard me earlier, is get a mentor. Get somebody that you can actually really trust. That mentor doesn't need to necessarily be a consultant, a professor, somebody high up. It's just somebody that you can, lean on. Somebody that you can, talk to and through the good times and the bad times, and give you a bit of advice and give you a sense check. Am I doing this right? What should I be focusing on? So really try and get somebody that you can depend upon, but somebody that you can really depend upon, not somebody that's gonna, you'll share something confidential with, and then it'll become the gossip in the doctor's mess or within the department, etc. I've learned that one. You need somebody you can really, really trust, that will have your back and support you, and not be a bystander if the going gets tough. That they're going to stick up for you as well. The other piece of advice is that if you really care and passionate about it, go for it. Of course. Look, I came from nowhere. Somebody not too long ago said to me, "Oh, but everybody, Phil. You know everybody, Phil." And I said, "Well, you might think that, So, but I literally came from nowhere. Nobody knew me. Nobody knew me at all. And many people still don't know me, of course. But I have been passionate and I have put myself out there. And I think if you're really keen and, passionate about something, you've got some good ideas, don't be afraid to suggest them, and yeah, of course, be ready to get shot down a few times. There's always people lining up, desperate to shoot you down, especially if they can see potentially your star metaphorically rising. That's medicine. We know it can be cruel, and we know that it can be cutthroat, etc. But still, just go for it. But going back to the very beginning, the most important thing by far, is that, remember, this is only a job. And, it pays your mortgage. If you've got a mortgage, it pays your rent. It gets you the holiday you want to go on. You need to look after yourself. You need to put yourself first. And that's why many of us, including retired people like me, fully back, what the junior doctors are doing now. They're striking, and, the more senior doctors, because, we can see that, I think as the profession across the board has just taken too much for too long, really. And this is what happens when goodwill goes and people, push back. And it's really, really very sad.
Thank you. Yeah, I know it is really sad to see. And, thank you so much, Phil, for really sharing that and sharing your thoughts on what's going on, because you've seen a lot of changes that's happened over your career, and a lot of good and bad things that have happened, and I want to kind of move on and talk about how your new chapter of your life in the next chapter, now that you've taken a step back from the clinical work and you can reflect a bit more, how you've reflected on your brilliant career so far.
Well, thank you. I mean, some would argue not so brilliant. Some may say it was brilliant, but I think I probably do have a sense of pride, of course. Nobody in my family have done what I've done before. I know what efforts and work and I put into. And so I think it's been tough. I mean, since I've retired, it's been really, really tough. I don't mind saying it out loud. It's felt like grief, actually. I worked incredibly hard for a career, really struggled through at times. I remember doing an on-call in small bowel obstruction, finished the on-call and then went to a hospital myself. I mean, just bonkers stuff. And I kind of got through those hurdles, put myself through a lot of pain and discomfort. And then it just feels premature that it's gone. So I do feel a sense of grief, possibly sadness. I feel a bit of frustration as well, that I still had lots of things I wanted to do. I mean, in the short period of time I was in Liverpool, we did amazing things. Some of the team, one of the things I was most proud of was our transition service was really flying, and getting the paediatric patients into adult services was a really good service, and we won a few prizes for that, which I was really proud of. So, yeah, I mean, frustration at things still could have been done and should have been done. So it has been really quite weird retiring at a younger age, such as I have. I think I've got a lot still to give in terms of potentially education side of things. I do some journal work. I call it work. It's a hobby, effectively, to be clear. And so, it's something I enjoy and something that I can, give back to the profession. But I don't know what to say, really. There's been a lot of reflection, and hopefully I've tried to crystallise what's been part of my reflection since I've retired.
Thank you very much for sharing those reflections on your career, Phil, and for speaking so candidly about the conflicted feelings you're left with. We're going to finish here for today, but we will be picking up the conversation again in the next episode. We'll be asking Phil about the changes in the profession since his career began, and getting his thoughts on the state of the NHS today and its impact on training. If you're enjoying the BSG Trainees podcast, we'd be very grateful if you could leave us a review or rating. wherever it is you are listening. We'll see you soon for the next episode. Thanks and take care.